Ankle pain is a frequent pathology, and patients often come to us in a very specific way to tell us that they have pain in front, behind, or on the side. So it will be necessary to adapt this examination according to the location of the pain. Let's see how to perform a study of the lateral part of the ankle. The two bundles of the anterior talofibular ligament, the proximal bundle and the distal bundle, are visible and insert on the lateral side of the talus. Here on the lateral side is the lateral process with the two bundles, the distal and proximal bundles. But there are other structures that must also be looked for, specifically the peroneal tendons, where peroneal tendon pathology is extremely common. It is divided into two parts. Initially, there is retromalleolar pathology. In this pathology, there is often an impingement between the compartment of the peroneal tendons and the lateral malleolus. What do we look for at this level? We need to look for three things. First, an absence of concavity of the posterior part of this lateral malleolus. Here we see that the malleolus is relatively flat at its posterior part, and even here relatively concave. Thus, there is no posterior convexity risking attack of the peroneal tendons. But there are two other elements that are also key to discover. The second one is the accessory tendon, the peroneus quartus. Here we see that there are only two tendons, peroneus longus here and peroneus brevis here, with its muscle developed posteriorly. Well, this muscle, which is very clearly hypertrophic in this patient, and that descends relatively low, may constitute the third element to look for in the event of retromalleolar pain of fibular origin. Then, we will test the position of the peroneal tendons. We will especially take a good look at their position in relation to the crest of the malleolus. We see that the insertion of the superior peroneal retinaculum takes place here at the corticoperiosteal level. We are going to do the eversion maneuver by putting pressure and asking the patient to raise my hand to the ceiling. There, we see that when he does this maneuver, the retinaculum is tensed. But we see that here, the tendons do not cross at the crest of the lateral malleolus. Go ahead and release. So then, there is no sign of dislocation, subluxation, or rupture of this attachment of the superior fibular retinaculum on the malleolus. Also note the presence of this small fibular cartilage deep in the retinaculum, which is clearly visible in this patient. The distal insertion of the superior retinaculum takes place on the calcaneus near the insertion of the calcaneofibular ligament, which is here. And here is the superior retinaculum of the fibula. And we see that the insertion of these structures is a joint, and a retinal and ligamentous thickening can enclose the fibular tendons. We saw the retromalleolar anatomy of the tendons. Let us now see the anatomy a little more distal under the malleolus. To find our locations, there is an interesting element that is the peroneal trochlea. It's an asperity of the cortex of the calcaneus that separates the two peroneal tendons. We know that at this point, the peroneus brevis will always be in front and the peroneus longus will always be behind. This fibular trochlea, which here is very small, can be extremely salient and come to separate the two tendons. This is an element likely to promote tendinopathy. We encounter this hypertrophy of the trochlea, especially in people who have a hollow foot. At this location, the peroneal tendons are pressed against the calcaneus by this structure that is the lower peroneal retinaculum. Its distal part is clearly visible and is inserted on the calcaneus. Its anterior part is less so, because it merges with the extensor retinaculum, analyzed during the study of the dorsal side of the ankle. This lower perineal retinaculum is the site of a very specific pathology, which is its thickening that grips the perineal tendons as if clamped in a vise. It is a stenosing pathology similar to that of the wrist with Quervain's tendinopathy. At this location, we can obviously see all the tendon pathologies. We can see tenosynovitis, fissures, as well as ruptures. We can also see calcifications and even see cysts. But to analyze the tendons correctly, we also have to rotate our probe 90 degrees to study them in their long axis. We know that the peroneus brevis tendon attaches to the base of the fifth metatarsal. We position the probe on the base of this fifth metatarsal, and we know that the fibular structure that is inserted there is the peroneus brevis. We then go up gently in the direction of the malleolus to follow this peroneus brevis to the submalleolar region. And we see that its fibular structure is perfectly preserved. We then lower the probe slightly toward the soles of the feet, and we know that there we find the peroneus longus. We follow it until it passes over the cuboid, where it is reflected, and at this place, as in this patient, it may contain an accessory bone. The fibula bone is important to analyze because its rupture can lead to that of the peroneus longus tendon. In addition, the fibularis longus can be irritated on contact with this particular fibula bone, as here when it is large. We see that the tendon fibers are really interrupted by this fibula. Then we study the passage of the tendon along the cuboid, but that we will see again when we study the plantar surface of the foot. So at that location, we have ligaments and we have tendons. But let's not forget that the tarsal sinus is very well studied and that a sagittal section within the sinus allows us to see the roots of the extensor retinaculum. It allows us to see the talocalcaneal ligaments, and it allows us to see the bifurcate ligament at its attachment to the calcaneal rostrum during the show part analysis as here, at the point of its attachment to the calcaneus. More distally, the calcaneal cuboid ligament can also be seen. To do this, we locate the space between the cuboid in front and the calcaneus behind, and we look for a fine fibular structure on the surface of this space. Another thing to remember is the lateral subtalar space. By making a section showing the peroneal tendons, we should know that in this same section, by positioning our probe submalleolar, the lateral subtalar space between the calcaneus and the talus anterior with the peroneal tendons and the calcaneal fibular ligament is in depth of these tendons. So when a patient comes in stating that they have pain on the side of their ankle, if it is outside the context of a sprain, it is necessary to look at the peroneal tendons, the superior retinaculum of the peroneal, the inferior retinaculum of the peroneal, the insertion of the fibularis brevis on the base of the fifth metatarsal, and the fibularis longus as it passes over the cuboid. We also look at the sinus tarsi to see if there is an effusion at this level, or even a cyst. because the subtalar leads to the formation of many cysts. So retinacular pathology, tendon pathology, and ligament pathology. This is what we will find on the lateral aspect of the ankle.